Welcome to the Hospital Medicine Unplugged podcast. Our mission today, well, it's really dedicated to providing a highly focused, evidence-based deep dive. We're looking at the acute management of hypercalcemia in hospitalized patients, and we're drawing insights heavily from recent landmark literature, I think publications in the NEJM, JAMA, and also the critical guidance from the latest Endocrine Society directives.
Yeah, this is a topic that really hits home for anyone in hospital medicine. Hypercalcemia, it's not some rare thing, right? It's common. And, while sometimes it's just an incidental finding on labs, it can really escalate fast. We're talking about a potential medical emergency. It can lead to significant multi-organ failure. So there's a real-time urgency here. And that's driven by, frankly, the high morbidity and mortality associated with it, especially in those severe cases. I mean, some data shows in-hospital death rates can get close to 17%.
Wow, 17%. That number alone really underscores why we need to be sharp on this. And when you look at the the big picture epidemiology for inpatients, it actually simplifies things a bit, doesn't it? Mm-hmm. The literature is pretty clear. The vast majority, something 90% of the cases we see in the hospital setting, they boil down to just two main causes, malignancy and primary hyperparathyroidism. If you can sort of triage into one of those two buckets quickly, you're already on the right track.
Absolutely. That initial sort is key. But before we jump into treatment, we need to make sure we're all using the same language, clinically speaking. So definition first. Hypercalcemia means a serum calcium concentration above the upper limit of normal. Typically, that's going to be greater than 10.5 milligrams per deciliter. But, the number itself isn't the only thing driving how fast we need to move. Classifying the severity is really the critical step for triage.
Right, that pace of response is everything in these acute situations. So we categorize mild hypercalcemia, that's usually a corrected calcium, less than 12 milligrams per deciliter. These patients, often they're asymptomatic, maybe feeling a bit tired, a little constipated, things like that. Nothing dramatic usually.
And then you have moderate hypercalcemia. That's in the range of 12 to 14 milligrams per deciliter. And here, symptoms are much more likely to pop up, especially if that calcium level shot up quickly.
And then there's the red line, severe hypocalcemia, defined as a corrected calcium greater than 14 milligrams per deciliter. This is officially a medical emergency. These folks are almost always symptomatic, often presenting with pretty dramatic neuropsychiatric stuff. They need immediate intervention, and, well, the workup has to happen simultaneously.
And here's something really interesting, a key clinical point that sometimes gets maybe underappreciated. The severity isn't just about the absolute calcium number. It correlates, crucially, with the rapidity of the rise.
Okay. Why does that rate of change matter so much clinically?
It boils down to adaptation, or really the lack of it. Calcium receptors, especially in the brain and the kidneys, they can sort of get used to higher levels over time. They slowly downregulate their sensitivity. So think about a patient with primary hyperparathyroidism who's been cruising along with a calcium of, say, 13.0 for a couple of years. They're often much less symptomatic than someone with a brand new cancer diagnosis whose calcium jumped from 11 to 13.5 literally overnight. That rapid, uncompensated increase just doesn't give the body any time to adjust, and boom, you get acute organ dysfunction.
That makes perfect sense. Okay, so let's unpack the why behind the high calcium, the underlying mechanisms. We know calcium homeostasis is this tightly controlled system, right, involving PTH, vitamin D, calcitonin. When it breaks down, it seems to fall into about 4 primary mechanistic categories.
Exactly. Mechanism number 1, which is actually the second most common cause overall, is excessive parathyroid hormone secretion. This is what defines primary hyperparathyroidism, or PHPT. So too much PTH jacks up calcium levels through like a triple attack. It increases bone resorption, pulls calcium out of the bone via osteoclasts, it enhances renal calcium reabsorption, so the kidneys hold on to more calcium, and it boosts intestinal absorption because PTH stimulates that key enzyme in the kidney, 1-alpha-hydroxylase, which cranks out more active vitamin D, calcitriol, that's 1.25 dihydroxyvitamin D.
Okay, so that's PTH itself. Now the second mechanism, and this is often the really dangerous one we see acutely in the hospital, is parathyroid hormone-related protein production, PTHr. This is the engine behind humoral hypercalcemia malignancy, right?
Precisely. And what's critical to understand is that PTHrP, well, it basically mimics PTH. Structurally, it's similar enough to bind to the same receptor, the type 1 PTH receptor, or PTHR1, on bone and kidney cells. So it causes the same downstream effects. More bone resorption, more renal calcium reabsorption. But here's the key diagnostic point. The malignancy is pumping out this PTHrP totally outside the body's normal feedback loop. So the body thinks calcium is high and tries to shut down PTH production. That's why the actual PTH level will be suppressed, usually very low. And this makes measuring the PTH level the single most important initial diagnostic test we can run.
Or that suppressed PTH is the big clue pointing away from primary hyperparathyroidism. And which cancers are typically doing this, using the PTHrP mechanism?
Yeah, PTHrP is definitely the most frequent mechanism in malignancy. We see it commonly with solid tumors. Think squamous cell, KOK-SI, lung, head and neck, also renal cell carcinoma, bladder cancer, and breast cancer too. Maybe up to 20% of breast cancers can produce PTHrP.
Okay, so mechanism 3 moves away from these circulating hormones and focuses more on direct local effects in the bone, direct bone metastases or osteolysis. That's right. Here, the tumor cells themselves have physically invaded the bone. They release calcium locally, largely by stimulating nearby osteoclasts through the release of various cytokines, things like IL-6 or TNF. You see this classically when there's really extensive bone involvement. Hematologic malignancies like multiple myeloma are a prime example. Or solid tumors that heavily metastasize to bone, like advanced breast cancer. Got it. And the fourth mechanism, you mentioned it's less common but important for treatment choices.
Yeah, number 4 is increased extrarenal activation of vitamin D. This one's a bit different. Certain lymphomas and also granulomatous diseases, sarcoidosis is the classic example. Their cells actually have their own 1-alpha hydroxylase enzyme activity. It's autonomous. So they bypass the kidney's normal regulation and just start churning out excessive amounts of active 1.25 dihydroxyvitamin D. This, in turn, drives up intestinal calcium absorption. Recognizing this mechanism is crucial because it completely changes the management approach, particularly regarding the use of glucocorticoids, which we'll definitely get into.
Okay, so tying this back to our hospitalized patients, we said malignancy and PHPT are the big two. And while PHPT might be more common overall in the population, when we're talking about severe hypercalcemia landing someone in the hospital, often critically ill.
Malignancy is the undisputed king there. It's the most common cause of that severe acute presentation. And like we mentioned up front, that diagnosis carries a pretty grim prognosis. It's directly linked to poor outcomes and significantly increased short-term mortality.
Right. Whereas primary hyperparathyroidism, the second most common overall, usually looks different, doesn't it?
Typically, yes. PHPT usually presents as more of a chronic condition, often mild, sometimes moderate, maybe even asymptomatic hypercalcemia found incidentally. It's usually caused by a benign parathyroid adenoma. So while these patients definitely get admitted to the hospital, they're rarely the ones crashing with, calcium of 16 and altered mental status requiring the ICU. That scenario. Much more likely to be humoral hypercalcemia of malignancy.
And of course, as hospitalists, we always have to keep our eyes peeled for those other potentially reversible causes. Medication reconciliation, that's often the low-hanging fruit, especially in mild or maybe moderate cases.
Absolutely. You've got to look for thiazide diuretics. Paradoxically, they increase calcium reabsorption in the distal tubule. Lithium's another one. It kind of messes with the PTH set point. And then the obvious ones. People taking megadoses of vitamin D or calcium supplements, often over-the-counter stuff they might not even think to mention.
Right, and don't forget things like prolonged immobilization, especially in patients with high underlying bone turnover. And the somewhat infamous milk-alkali syndrome, though maybe less common now than it used to be.
Still happens, though. Definitely need to ask about calcium-containing antacids or supplements.
Okay, so given all these potential causes, let's shift to how patients actually present. We all know the classic mnemonic, right? Stones, bones, groans, and psychiatric overtones. It's catchy. But for the acutely ill, hospitalized patient, it really seems like those psychiatric overtones and the renal symptoms are often the most immediately dangerous, the things most likely to land them in critical care.
You nailed it. On the neuropsychiatric front, the symptoms really track with the calcium level and, again, how fast it rose. We see confusion, lethargy, progressing to stupor, and even coma. It's essentially a rapidly developing encephalopathy. For gastrointestinal complaints, think severe nausea, intractable vomiting, significant constipation, anorexia. And importantly, that volume loss from vomiting just makes the hypercalcemia worse. It fuels a really nasty, vicious cycle. Acute pancreatitis is rare, but it can happen. The mechanism isn't perfectly clear, maybe something to do with calcium activating pancreatic enzymes prematurely.
But the renal effects, those seem especially critical in the acute setting because they directly cause volume depletion and drive acute kidney injury, right?
Exactly. Those are incredibly important. Patients develop polyuria, They're making lots of urine and polydipsia. They're incredibly thirsty. This happens because high calcium impairs the kidney's ability to concentrate urine, leading to a state called nephrogenic diabetes insipidus. All that urine output rapidly leads to dehydration. And acute kidney injury, or AKI, is remarkably common. We see it in over 80% of critically ill patients with severe hypercalcemia. It's mostly driven by that profound volume depletion, but also high calcium itself is toxic and causes vasoconstriction in the kidney tubules.
Oh, 80% AKI prevalence. That's huge.
Yeah.
And then the cardiovascular system, we can't forget that. Hypercalcemia can be arrhythmogenic.
Definitely. Clinically, we look for that characteristic shortened QT interval on the ECG. That's a classic finding. But if the calcium gets high enough, you can see all sorts of arrhythmias, bradycardia, a slow heart rate. And, crucially, it dramatically increases sensitivity to digoxin toxicity if the patient happens to be taking that medication. A really important drug interaction to remember. The potential severity of all these manifestations often means we have to start treatment before we even have the full lab panel back.
Okay, that makes sense. Moving on to the diagnostic evaluation itself, what's step one?
Step one, always, is confirming it's true hypercalcemia. We measure serum total calcium, sure, but remember, a big chunk of calcium, maybe 30 to 40%, is bound to protein, mostly albumin. So if your patient has low albumin, which is super common in hospitalized patients, the total calcium might look falsely normal or only mildly elevated. You absolutely must correct for hypoalbuminemia.
Right, that formula is practically burned into our brains. Corrected calcium in milligrams per deciliter equals measured calcium plus 0.8 times 4.0 minus the serum albumin in grams per deciliter. Always got to run that calculation if you're looking at total calcium.
Exactly. But let's pause on that formula for a sec. While it's necessary if total calcium is all you have, it's not perfect. Far from it, actually. It can sometimes underestimate the true calcium level if the albumin is really, really low. Or it might overestimate it if there's, say, hypergammaglobulinemia, like in multiple myeloma. Which is why if you can get it, and especially if the clinical picture seems off or confusing, ionized calcium is really the preferred test.
Ah, good point. Why ionized?
Because ionized calcium measures the fraction that's not bound to protein. It's the biologically active form of calcium. And since it's not affected by albumin levels or other protein issues, it gives you a much more accurate picture of the physiologically relevant calcium status. So if it's available, definitely consider ordering an ionized calcium.
Okay, ionized calcium preferred if available. Once we've confirmed true hypercalcemia, what's the next critical lab? The cornerstone of the etiologic workup.
That would absolutely be the parathyroid hormone, PTH level. The single test is pivotal. It basically directs the entire subsequent investigation and often gives you a huge clue about the underlying cause and what kind of definitive therapy might be needed down the line.
So how does the PTH level guide us?
It's pretty straightforward, actually. If the PTH level comes back elevated or even inappropriately normal, given that the calcium is high, meaning the parathyroid glands should be shut down by the high calcium, but they aren't. That's the classic fingerprint of primary hyperparathyroidism. If the patient's symptoms are mild or chronic, it usually points towards PH-PT caused by a benign adenoma.
Okay, and the flip side, what if the PTH is low?
Right. If the PTH is suppressed, often very low, like less than 20 picograms per milliliter, that tells you the hypercalcemia is not being driven by the parathyroid glands. This strongly suggests a non-PTH-mediated cause. And that immediately steers us towards thinking about malignancy, or maybe a vitamin D issue, or possibly medications.
So suppressed PTH means look elsewhere.
Yeah.
What are the follow-up labs in that scenario?
If the PTH is suppressed, you then order a cascade of additional tests to figure out the specific non-PTH mechanism. You'll want to check a PTH-related protein, PTHrP level. You'll also want both a 25-hydroxyvitamin D and a 1.25 dihydroxyvitamin D level.
Okay, and how do we interpret those results together?
You look at the pattern. If the PTHrP comes back elevated, bingo. You've likely got humoral hypercalcemia of malignancy. If the 25-hydroxyvitamin D is high, that usually points towards external sources the patient is taking too much vitamin D supplement, maybe vitamin D intoxication. Now, if the 1.25 dihydroxyvitamin D is high and the PTHrP is negative, that's when you suspect that extrarenal activation mechanism we talked about, think granulomatous disease like sarcoidosis or certain lymphomas. It's also helpful to look at the serum phosphate level alongside these.
How does phosphate help?
Typically, in PTH-driven or PTHrP-driven hypercalcemia, the phosphate level will be low or low normal. That's because both PTH and PTHrP decrease phosphate reabsorption in the kidney tubules, so you pee out more phosphate. Conversely, in vitamin D-mediated hypercalcemia, whether it's from intoxication or extrarenal production, the phosphate level might actually be high or high normal because vitamin D promotes phosphate absorption from the gut and reabsorption in the kidney. So phosphate can be another useful clue.
Got it. And we'd also be checking creatinine, obviously, to gauge the degree of kidney injury. You also mentioned a 24-hour urinary calcium sometimes. When does that come into play?
Yeah, the 24-hour urine calcium is less critical in the acute setting usually, but it can be important, particularly if PH-PT is suspected based on the labs. Its main role there is to help rule out a rare condition called familial hypercalcemia, or FHH. FHH mimics PH-PT with high calcium and non-suppressed PTH, but it's caused by a genetic mutation affecting the calcium-sensing receptor, leading to very low calcium excretion in the urine. It's usually benign and doesn't require surgery, unlike most PH-PT. But again, like you said, in severe acute hypercalcemia, the absolute priority is starting treatment. These diagnostic labs often run in parallel while we're aggressively resuscitating the patient.
Exactly. Which brings us perfectly to the really crucial part for our audience. The evidence-based acute management in the hospital. What is the absolute first non-negotiable priority action?
Vigorous volume repletion, no question. This is job number one for basically all patients with moderate to severe hypercalcemia or anyone who's symptomatic. Why? Because these patients are almost always profoundly volume depleted, mainly due to those renal losses we discussed, the polyuria. Correcting that volume deficit is paramount. It helps restore perfusion, and it directly helps lower the calcium level by promoting calciuresis, flushing calcium out through the urine. It's step 1, 2, and 3.
Okay, so fluids first. What kind of fluid and how much?
The agent of choice is intravenous isotonic saline, normal saline. Volume expansion does more than just rehydrate. It actually reverses some of that hypercalcemia-induced vasoconstriction in the kidneys, which helps improve the GFR, the glomerular filtration rate, and maybe even more importantly, when you flood the proximal tubule with sodium by giving lots of saline, it overwhelms the kidney's ability to reabsorb calcium along with the sodium. Calcium sort of follows sodium passively there. So simply put, giving a lot of saline is a very effective, natural way to get the kidneys to dump calcium.
And the rates need to be pretty aggressive, at least initially.
Oh, yeah. We're often talking about starting with a bolus, maybe 1 to 2 liters of normal saline pretty quickly unless there's a contraindication, followed by continuous maintenance rates that can be quite high, often in the range of 200 to even 500 milliliters per hour initially. The goal is twofold. Achieve clinical euvolemia, get their volume status back to normal, and then maintain a really brisk urine output, ideally aiming for something like 100 to 150 milliliters per hour to maximize that calcium excretion.
Now, that sounds like a lot of fluid. There must be a major caveat there, right?
Absolutely. And this is where careful clinical monitoring is essential. The big risk with such aggressive fluid resuscitation is volume overload, pulmonary edema. This is mandatory to watch for, especially in our elderly patients or anyone with known heart failure or significant kidney disease. You have to be at the bedside, frequently assessing lung sounds, looking for JVD, checking peripheral edema, maybe monitoring CVP if you have central access. You absolutely have to titrate those fluid rates based on the patient's response, their cardiac tolerance, and hitting those urine output goals. You can't just set it and forget it.
Right. Can't just blindly pour in fluids. Which leads us naturally to the sometimes controversial role of loop diuretics, like furosemide. What's the current thinking there?
The consensus across guidelines is pretty clear now. Loop diuretics should really only be considered after you've achieved euvolemia with saline. Using them up front when the patient is still volume depleted can actually be harmful. It can worsen the dehydration, potentially exacerbate the AKI, and might even hinder calcium excretion initially.
So they're not a primary treatment for hypercalcemia itself?
Not really. We reserve loop diuretics, typically furosemide, maybe 20 to 40 milligrams IV, primarily for patients who are developing signs of fluid overload during saline resuscitation or those at very high risk for it. Their main purpose in this context isn't to lower calcium directly, although they do inhibit calcium reabsorption in the loop of Henle to some extent. It's more about helping the patient excrete that massive saline load you're giving them, basically to prevent them from going into pulmonary edema, while still allowing you to maintain that high urine flow rate needed for calciuresis.
Okay, so fluids managed carefully, diuretics used judiciously only after volume repletion. What's next in the pharmacologic strategy? We need to target the underlying problem, which is often excessive bone resorption.
Exactly. Once we're addressing the volume status, we move to drugs that directly inhibit osteoclasts, the cells that break down bone and release calcium. And historically, the bisphosphonates have been the mainstay for achieving sustained control of hypercalcemia, especially in malignancy. They work by basically poisoning the osteoclasts, inducing apoptosis, and shutting down that engine of calcium release from the skeleton.
What are the common agents and what are the drawbacks?
The main challenge with bisphosphonates is their onset of action. It's delayed. You typically don't see a significant drop in calcium for 24 to maybe 72 hours. But the good news is, once they kick in, their effect is usually quite potent and can last for several weeks, which is great for sustained control. The key agents we use intravenously are zoledronic acid, usually given as 4 milligrams MyFe over about 15 minutes, and pomidronate, typically dosed at 60 to 90 milligrams to 5, but infused over a longer period, usually 2 hours or more.
Okay, zoledronic acid or pomidronate. Is there a reason to choose one over the other? You mentioned infusion time difference.
Yes, and the big differentiator, which is critical for hospitalists to consider, often guided by local protocols and patient factors, is renal function and potential nephrotoxicity. Zoledronic acid is very effective, perhaps slightly more potent than pomidronate in some studies, but it carries a higher risk of causing acute kidney injury, especially if given too fast or in patients with pre-existing renal impairment. Guidelines generally recommend caution. Dose adjustments are sometimes needed, and often it's avoided altogether if the patient's GFR is below, say, 30 or 35 milliliters per minute. Pomidronate, because it's infused more slowly, is generally considered safer in patients with moderate renal impairment. It's often the preferred agent in that setting. The absolute bottom line, though, you must check the patient's creatinine and calculate their GFR before you administer the first dose of any IV bisphosphonate.
Critical safety check. Okay, so bisphosphonates are the workhorse for long-term control, but they take a day or two to work. What do we do for more rapid lowering, especially in those severe cases where the calcium is dangerously high right now?
That's where calcitonin comes in. It acts as a rapid bridge therapy. It offers a much faster, though usually more modest and transient, reduction in calcium levels. Its onset is typically within hours, maybe 4 to 6 hours.
How does calcitonin work and how do we give it?
Calcitonin works by directly inhibiting osteoclast activity and also by increasing renal calcium excretion. We typically use salmon calcitonin, given either subcutaneously or intramuscularly. The dose is usually weight-based, around 4 to 8 international units per kilogram, typically given every 8 to 12 hours. But there's a major catch with calcitonin, a significant clinical limitation.
Yes, you mentioned this earlier, tachyphylaxis.
Exactly. Tachyphylaxis is the big problem. The body very quickly develops resistance to calcitonin's effects, probably due to downregulation of its receptors. This means its effectiveness is really limited, usually only lasting for about 48, maybe 72 hours at most. So while it's a useful adjunct in that initial critical period, especially for severe symptomatic patients waiting for the bisphosphonate to kick in, you absolutely cannot rely on calcitonin for sustained calcium control beyond 2 or 3 days. It's a bridge, not a long-term solution.
Okay, bridge therapy with calcitonin. Now, what about denosumab? You mentioned this is becoming increasingly important.
Yes, denosumab is a major player now, especially in certain situations. The standard dose used for hypercalcemia of malignancy is 120 milligrams given subcutaneously.
And how does it work differently from bisphosphonates?
It targets a completely different pathway. Denosumab is a monoclonal antibody against R-ANK ligand, or RANKL. RANKL is essential for the formation, function, and survival of osteoclasts. So by blocking RANKL, denosumab effectively shuts down osteoclast activity through a different mechanism than bisphosphonates. This different mechanism makes it particularly useful in cases of hypercalcemia of malignancy that are refractory to or relapse after bisphosphonate therapy.
Okay, so useful in refractory cases. What's the other big advantage?
The other massive advantage, and this is really key, is its metabolism. Denosumab is a protein, a monoclonal antibody. It's cleared by the reticuloendothelial system, not by the kidneys. It is not renally cleared. This is huge. It means denosumab can be used safely and effectively even in patients with severe renal impairment or acute kidney injury, where bisphosphonates are often contraindicated or require significant dose adjustments and carry risk. Because of this, recent guidelines are increasingly recommending denosumab not just for refractory cases, but potentially as a first-line agent in patients with hypercalcemia of malignancy, especially if they already have significant renal dysfunction.
That's a really important point about the renal clearance, potentially shifting first-line therapy in some patients. Okay, beyond those main agents fluids, bisphosphonates, calcitonin, denosumab, are there other important etiology-specific treatments we need to know? Let's start with glucocorticoids. When do they fit in?
Glucocorticoids like prednisone have a very specific niche. They are primarily indicated for hypercalcemia that's driven by excess vitamin D activity. So think back to that fourth mechanism we discussed, hypercalcemia, caused by conditions like sarcoidosis, other granulomatous diseases, or certain lymphomas that produce their own active vitamin D. The mechanism of action is pretty direct. Glucocorticoids inhibit that abnormal 1-alpha hydroxylase enzyme activity within those granulomas or tumor cells. By doing that, they reduce the overproduction of active 1.25 dihydroxyvitamin D, which in turn decreases excessive intestinal calcium absorption. A typical starting dose might be something like prednisone, 60 milligrams daily, often for about 10 days, then tapered based on response. Importantly, just giving a bisphosphonate to these patients often won't work very well unless you also address the underlying vitamin D overproduction with steroids.
Okay, so steroids for vitamin D-mediated causes. What about specific treatments for refractory primary hyperparathyroidism, maybe in patients who can't get surgery quickly? You mentioned cinacalcet earlier.
Right. Cinacalcet is another tool, though used less often in the acute setting compared to the others. It's a calcimatic agent. It works by basically tricking the parathyroid gland. It increases the sensitivity of the calcium-sensing receptors on the parathyroid cells to the existing calcium levels in the blood. This makes the gland think the calcium is higher than it is, which leads to a decrease in PTH secretion and subsequently lowers the serum calcium. Its main indications are for the very rare parathyroid carcinoma, or sometimes for managing severe refractory primary hyperparathyroidism in patients who are not surgical candidates or awaiting surgery. It's usually started at a low dose, like 30 milligrams daily, and titrated up.
Got it. And then the absolute last resort, when everything else fails or isn't possible, dialysis.
Yes, dialysis is reserved for truly life-threatening refractory hypercalcemia. We're talking levels maybe greater than 18 milligrams per deciliter, especially if it's occurring in a patient with severe acute or chronic renal failure where they can't excrete calcium, or if the calcium level just isn't budging despite aggressive fluids and appropriate medications. If you do need to use dialysis, it's crucial to use a dialysate bath that has low calcium, or ideally is completely calcium-free. That creates the concentration gradient needed to effectively pull large amounts of calcium out of the patient's blood.
Okay. Dialysis is the rescue therapy. And throughout all of this, we can't forget the basics, right? That fundamental hospitalist role.
Absolutely. You hit on it earlier, medication reconciliation. It seems simple, but it's critical. As soon as hypercalcemia is identified, you have to meticulously review the patient's medication list, including over-the-counters and supplements. You need to identify and immediately discontinue any potentially offending agents, stop the thiazide diuretics, stop lithium if possible, stop the vitamin D supplements, stop any extra calcium carbonate or Tums the patient might be taking, unless there's some overwhelming reason they need it. Missing a thiazide on the admission med list is such a common pitfall, and it can really delay getting the calcium under control unnecessarily.
Such a key point. Okay, let's zoom out a bit and talk about the longer view prognosis and definitive treatment. We know untreated severe hypercalcemia is bad news, at least that predictable rapid multi-organ dysfunction, high morbidity. You mentioned the neurologic progression, confusion, potentially spiraling down to coma. That's terrifying.
It is, and the kidney impact really warrants emphasis again. We talked about that high prevalence of AKI, over 80% in severe cases, and it's not always transient. Data suggests that up to maybe 19%, nearly 1 in 5 of those critically ill hypercalcemic patients might end up needing some form of renal replacement therapy, like dialysis. That's a major complication. Plus, the cardiovascular risks are real, those arrhythmias, the bradycardia, potentially even cardiac arrest in extreme cases. It all highlights why prompt and aggressive initial management with fluids and targeted meds is so vital.
And the long-term prognosis, as we've kind of alluded to throughout, seems entirely dependent on why the calcium was high in the first place. The underlying etiology is everything for the long haul.
Completely. If the diagnosis turns out to be malignancy-associated hypocalcemia, HCM, the prognosis is, unfortunately, almost universally poor. We mentioned that in-hospital mortality for severe cases is concerningly high, around 17% in recent studies. And even if we successfully manage the acute hypercalcemia in the hospital, get their calcium back to normal. Sadly, most patients diagnosed with HCM still succumb to their underlying cancer within about a year. Our acute management in HCM is really supportive and palliative in many ways. It buys time, but it doesn't change the underlying trajectory of the cancer itself.
That's a sobering reality for HCM. But the picture is vastly different if the cause is primary hyperparathyroidism, PHPT, isn't it?
Oh, absolutely. It's night and day. If the etiology is PHPT, typically from a benign adenoma, the prognosis after definitive treatment is generally excellent. The definitive therapy here is surgical parathyroidectomy, removing the overactive gland or glands, and surgery is highly effective. It's curative in over 95% of cases. It offers a true long-term fix for the hypercalcemia.
And what about those patients with milder PHPT who maybe don't meet criteria for surgery right away or choose conservative management?
For many patients with mild asymptomatic PHPT, conservative management with monitoring is a reasonable option. Most will remain clinically stable for years. However, long-term data suggests that a significant portion, maybe up to 40%, will eventually develop indications for surgery over a period of 10 to 15 years. Things like worsening bone density, development of kidney stones, a significant rise in their calcium level, or reaching a certain age threshold. There's also some observational data, though not definitive randomized trial proof, hinting that successful parathyroidectomy might modestly reduce long-term mortality risk compared to continued observation in certain patient groups.
Interesting. So the ultimate goal during the hospitalization, once the patient is stabilized from the acute hypercalcemia, is really to bridge them towards that definitive therapy, whatever it may be.
Precisely. For the patient with PHPT who meets surgical criteria, the goal is to get them safely through the acute episode and facilitate a prompt surgical consultation for parathyroidectomy. For the patient with HCM, the hospitalist's role beyond acute stabilization is to coordinate seamlessly with the oncology team. Definitive management in this case means effective cancer-directed therapy, chemotherapy, radiation, immunotherapy, whatever is appropriate for their specific malignancy. Our acute calcium management is purely supportive care, essentially buying time and improving symptoms, allowing the oncologist to implement their treatment plan.
Okay, so let's try to synthesize the core evidence-based approach we've discussed. What are the absolute key takeaways for managing acute hypercalcemia in the hospital?
I think it boils down to a few key principles. First, rapid assessment is crucial. Recognize the potential severity based on symptoms and the calcium level. Corrected for albumin or preferably using ionized calcium. Second, aggressive fluid resuscitation with isotonic saline is the immediate priority for almost everyone who is moderate, severe, or symptomatic. Correct the volume deficit and promote calciresis, but monitor carefully for overload. Third, initiate pharmacologic therapy targeted at inhibiting bone resorption. This needs to be carefully tailored based on the severity, the patient's renal function, and the suspected underlying etiology, which is primarily guided by that initial PTH level.
Right, and that tailoring involves choosing between bisphosphonates, calcitonin for bridging, denosumab, especially if renal function is poor or refractory HCM, and maybe glucocorticoids if vitamin D excess is suspected.
Exactly. And always remember the basics, stop offending medications. And finally, think about the definitive treatment based on the etiology surgery for PHPT, cancer-directed therapy for HCM.
Perfect summary. Now, this emphasis on tailoring treatment, particularly considering renal function and the underlying cause, brings us back to that final provocative thought you wanted to leave our listeners with, especially regarding humoral hypercalcemia of malignancy, HCM.
Yeah, this is something I think we'll be grappling with more and more. We've seen substantial emerging data supporting the use of denosumab in HCM. We know it works via a different mechanism, and critically, it's not renally cleared. This makes it particularly attractive for cancer patients who often have pre-existing renal dysfunction or develop AKI, precisely the setting where traditional first-line bisphosphonates carry a clear risk. So the question becomes, how aggressively should we be incorporating denosumab as a first-line agent in these high-risk HCM patients, perhaps even before waiting for bisphosphonates to fail or proving contraindicated, especially in patients with known malignancy and compromised kidneys from the start? Is the long-standing era of the IV bisphosphonate being the universal default acute agent for HCM potentially starting to shift, at least for the sickest patients with renal issues?
That's a fascinating question. Definitely food for thought about optimizing our initial HCM management strategies based on individual patient risks, particularly renal function, something for all of us to consider in our practice.